Really quickly, I'm just going to introduce our speakers, and Meg, if you have anything else to say at the end, feel free to jump on in. So today speaking, we have Dr. Shweta Sharma from the Menninger Clinic. She is a senior staff psychologist there at the Compass program for young adults, as well as an assistant professor in the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. Her expertise includes psychoanalytic psychotherapy, personality assessment and trauma. Her research interests include personality disorders, trauma and dissociation-related disorders, and psychotherapy processes and outcomes. Our second speaker today is Shelly Simpson, who is the clinical director of Ellenhorn's LA team. She has a passion for helping people integrate back into the community and build a life worth living. She actually previously worked for the Menninger Clinic in Houston as a program manager for the Pathfinder Community Integration Program. So without further ado, I'm going to pass it over to Shelly and Shweta.
Great. Thank you, Leah and Meg, for the warm introductions. It's nice to see some familiar faces and have everyone join today. I do just want to take a minute to say I really appreciate you all joining. I know that there's a lot of virtual stuff still happening, and it means a lot that you are spending an hour of your time with Shweta and I, and we hope we make it worth your time. Please do utilize the chat feature if you have a question that pops up while one of us is talking. Leah will help me sort of keep track of those. You might even see me with a pencil and handwriting a little bit, just in case something comes to mind that I don't want to forget. So to give you a little bit of information, I did work at the Menninger Clinic before. I've worked closely with Shweta, and we're joining forces to work together to share about the mind and the system, mentalization and AMBIT. Just going to throw this out here at the forefront. AMBIT stands for Adaptive Mentalization-based Integrative Treatment, but it is a word you will just hear thrown around loosely because that acronym is a lot for me to say. So without further ado, Shweta, why don't we just take it from here and talk to us a little bit about mentalizing?
Yeah, that sounds good. Thanks, Shelly, and thanks, Leah and Megan, and thank you all for stopping by. So what I'm going to do is I'm going to quickly review what you already know and get the boring stuff out of the way so that we can talk about more interesting stuff, you know. So just to get us started, I'll start with the definition. Now, keep in mind that I'm not going to say anything original here. I'm going to just liberally quote Peter Fonagy, Anthony Bateman, John Allen. You know, these are the people that I've learned everything that I know about mentalizing from. So here's a definition from Peter Fonagy, that mentalizing is a form of imaginative mental activity, okay? And the activity is, what are we imagining? What are we doing? That we interpret, we perceive and we interpret human behavior in terms of intentional mental states. So when we are making sense of ourselves and other people, we are trying to think about mental states like needs, desires, feelings, beliefs, goals, purposes, reasons that are driving our own behavior or other people's behavior and our interactions. So in short, mentalizing is holding mind in mind. But when you hear that phrase, it sounds too intellectual, too cognitive, right? But if you think about us making sense of ourselves and others, it's not just thinking, we feel it, right? So I think the phrase that better captures the essence of it is holding heart and mind in heart and mind. So that's the spirit of this, you know, and as you can see, that a lot of this is quite intuitive. We're doing it all the time. It's not conscious, it's not deliberate, it's not reflective, it's automatic, and it's implicit. And in a way, we could think about therapeutic work as making some of this implicit stuff explicit. But we'll come back to that. So we're doing this all the time, right? This imaginative activity. And this is the essence of our humanity, if you will, that it is as old as human relatedness. It's as old as self-awareness. But we could all, so in a way, it's hard to imagine us being not aware of our feelings or desires or wishes, like what Baron Cohen calls mind blindedness, you know. But we could all do it better. We could all learn to do it more skillfully. So that's an endeavor that hopefully is sort of the stance of all therapeutic work and maybe all relational work, that we are trying to mentalize more skillfully. So here's an example of common mentalizing failure. So this is from Jack Cornfield from the book, The Wise Heart. So this is in quotes. I love the story told by the mother of a 5-year-old girl. The child had taken a stethoscope out of her mother's doctor bag and was playing with it. As she put the stethoscope to her ears, her mother thought proudly, she seems interested in medicine. Maybe she'll grow up and become a doctor like me. After a time, the little girl put the listening end of the stethoscope up to her mouth and exclaimed, "Welcome to McDonald's. May I take your order, please?" At this, the mother had to laugh with her daughter and smile to herself about how easily we can project our ideas on one another. So we are all mentalizing all the time, but we are also, getting it a bit wrong or distorting it all the time, So what does the theory say? So this is what the theory says, that broadly, that all mental states are opaque. And we make inferences about them all the time. And that our inferences are prone to error. So we should take an inquisitive stance. We should try and be curious. And as we are curious, we can think of it in many different ways. But one way to think about it is that we're trying to see ourselves from outside, and we are trying to see others from inside. Or we are trying to understand the misunderstandings. Broadly, all interpersonal behavior is characterized, hopefully, by an expectation that one's mind may be influenced, surprised, changed, and enlightened by learning about another's mind. So the thing that is cool about the concept, although also problematic, is that it's too broad, It sort of is encompassing, all encompassing. It captures, it can explain anything, right? So the thing that I like about the theory is that it gives us a way to focus on this activity that we are immersed in all the time. What we call facets of mentalizing or dimensions of mentalizing. And one I already touched upon, that it can be automatic, but we can also make a conscious effort to think about what is going on with us, what's going on in another person's mind. Why have they gotten upset? How come they look tired? What's going on with them? So that's is control mentalizing, which is we're shifting from automatic to control. Now, in trusted relationships, we are not engaging in control mentalizing. We're just doing it. And it's a good idea to not switch to control, because that would make it a bit awkward, right? So the idea is not that one is better than others. I think the idea of health is, can I flexibly adapt to what is required in the moment? Can I switch from automatic to control when needed, when the stress is high or something unexpected has happened? And can I actually trust my relationships enough to lower down the guard and actually engage in this automatic, reflexive kind of interaction where I'm not closely guarding what I'm saying and how I'm saying it or how the other person is listening? So maybe that's what's the definition of, health is. So the other dimension is what am I mentalizing? Like, what am I attending to? Is it internally focused or is it externally focused? So externally focused is you're looking at my face, a little bit that you can see, or my body language, what is visible and physical. And internally focused is, thoughts and feelings that you can see. So again, if you use a clinical example, then the imbalance can be a problem. If you think of people with borderline personality disorder, they are too externally focused. They are hypersensitive to your body language, to your facial expression. They read it so well, maybe even better than most of us, but they're not able to then have a story about it that includes the internal stuff, which is the wishes, desires, fears, conflicts. They're not able to actually make up a story. So this hypersensitivity creates a lot of distress for them, because they might see Shelly and say, gosh, she's not paying attention, so she doesn't like me. And they're not able to actually now engage with Shelly. They would have real hard time as to, is this really about me, or is something going on with Shelly? Is there another perspective on this? So the imbalance can be a problem. The other dimension is, what's the focus of mentalizing? Is it the self or the other? So I could be mentalizing myself, or I could be mentalizing the other. So now the impairment can show up in different ways. One, it can be a global sort of impairment where the person really has difficulty about identifying their feelings, understanding their feelings, explaining their feelings, So that would be sort of true for both themselves as well as others. Like a person with psychosis, for instance, they have an issue around difficulty around identity, thinking about themselves, but they also then have very difficult time understanding others' mind. But the difficulty can be a different kind, where it's an imbalance rather than a global sort of difficulty in understanding oneself and others. Although these things go together, but think of narcissistic personality disorder, for instance, that they are much better at or much more interested in their own mind than others' mind. So it's too much self-focus, not enough focus on the other. So that's an example of imbalance. And in treatment, I think the way this helps us is that we want to pay attention to where the impairment is and move the person along, rather than, because the person, so facets actually help identify the difficulty in mentalizing, that what in the surface look like, yeah, this is all okay, but when you attend to the facets, you might actually discover, oh, this person really has hard time actually thinking about other people. So you identify an important area of focus that can be very helpful. The fourth dimension that they identify, the theory identifies, is cognitive and affective. That we could be thinking about thinking, and we could be thinking about feelings. And the work is the integration. And we all know some people who are really good at, being able to think about things, but are not in touch with their feelings. And we also know a lot of people who are more in touch with their affect, but have hard time then having a language for it and being able to speak about it in a coherent way. Okay, so it's a dynamic capacity. It's multifaceted, and it changes with the level of stress or arousal. That we need an optimal level of arousal in order to have mentalizing online. Too much arousal makes it hard to, it diminishes our ability to mentalize. And if it's too cold, if I'm not activated at all, if I'm not aroused at all, then I may be, then I'm not interested. I'm not interested in mentalizing. So optimal arousal, like an attachment relationship, like a therapy relationship, sets the stage for us to be curious about. Once we feel safe and trusted, then we get curious about our own mind and the other person's mind. And mentalizing begets mentalizing. More we do it, more it's like a virtuous cycle. And non-mentalizing begets non-mentalizing, meaning we can get stuck in a non-mentalizing mode. So what do we look at when we are working with people? I think it's helpful in all that we do. It's helpful to pay attention to whether mentalizing is online or not, because that's the basic minimum requirement for doing the work, doing the relationship, for having the communication, that mentalizing is online. It doesn't have to be controlled and explicit. It can be implicit. But when there's a break, then we have to make that a focus before we can talk about anything else or attend to anything else. So I'm going to stop there and go back to Shelly. Yeah.
That's great. Thank you, Shweta. And as Shweta is talking too, I want you all to think about not only your interactions with clients, but maybe your interactions with your own team members, right? Your interactions with networks. My light keeps turning off. I don't know why that's happening.
We'll try and mentalize that.
I know, right? They are doing construction in the office next door, so I wonder if it has something to do with that. But so if you see me sort of like my arm like this, I'm just turning it back on, just to share my mind. But anyways, so I want you to think about what Shweta was shared and how you've seen clients like that, how you've interacted with team members like that, how you've interacted with other complex systems. You know, maybe you're a social worker who has to work with a hospital nurse, or maybe you're a social worker who's working with a primary care doctor. And this is because what I'm about to talk about is AMBIT. And AMBIT is a system of care. It's not a type of treatment. It's not sort of in place of DBT. It is a system of care. And in the heart of this system is mentalization. You don't have to be a pro at mentalization to be sort of on an AMBIT system or in an AMBIT system. You need to know enough to be able to mentalize your colleagues and your clients and your networks. By no means do I want you to leave here today thinking I have to be a pro in this in order to be a pro in this. It's really all just, can we do it good enough, right? So first I want to give credit where credit is due for AMBIT. So AMBIT was first sort of bubbling up in the 90s. It was going under a different acronym. It wasn't quite sort of involving mentalization yet. It was Peter Fonagy and some folks in West London who were sort of starting to do this initial, like, how do we really integrate these complex systems of care with these complex clients? How do we work with these people or these young adults or these teens or children who don't trust this system? So a couple of years down the road, around 2009, AMBIT was given its official title, and it was focused on adolescents. And then a couple of years after that, they realized, wow, this is actually a system of care that can work for a wide range of people, in which they dropped the adolescent piece in called the A adaptive. Because in its nature, this system of care is adaptive. It is about flexibility over rigidity. So as I'm talking today, I'm going to share some examples from my work at Ellenhorn, but my work is definitely not the end all be all of how the system works. To throw out some of the people I have learned from, I have learned a great deal from Dickon Bevington, Peter Fugel, Liz Cracknell, and Peter Fonagy about AMBIT. I have a textbook I absolutely love from them. I'll sort of show it at the end if anyone's interested in learning more. It is something I ground myself in when I am feeling ungrounded. Sort of AMBIT put simply, which I think is important to start with, is just a small team approach. At Ellenhorn, our teams can get as big as like 10 people working with one client. And if you have ever experienced working with a client who's difficult to engage or who doesn't trust treatment or has a diagnosis of a personality disorder, complex trauma, that's a lot of people to throw at them. That is going to sort of arouse their attachment system, which is either going to shut them down so that when we go to their door to deliver medication or to have our appointment, because Ellenhorn works in the community with folks, they might not let us in. Or when they do let us in, we find someone who's completely dysregulated, right? And it's really our job to not put people in those positions. And so when someone's coming through the admissions process at Ellenhorn, we're sort of looking and we're seeing, there's certain markers we look for, and we take this small team approach. And this small team approach really sort of spreads the hierarchy of the care out. So it makes it so that we are all sort of coming from an even playing field with this client. So we're all presenting ourselves in an even way. We're not saying, this is your doctor runs the case and she knows best, so we have to funnel everything through her. We're saying, we work together as a team in this system that wraps around you, and our conversations are transparent and they're collaborative. And that's because you are the main part of this system. AMBIT, often mentalization as well, moves a client into an expert role. When people have been in and out of treatment, when they've had treatment failures, they often really start to not feel like the expert of their own life. They start to feel like they're discharge papers from their unit. They start to feel like jargon and not people. And in AMBIT, we really want to put the person back in the driver's seat of their life. With this small team approach, this means that there's some members who don't work with the client directly. And it is those people's job to sort of wrap around the rest of us who are working directly with the client, to take any extra work off our shoulders, to help us mentalize, turn all that stuff back on. It's a really sort of team-oriented system. The system itself, AMBIT, has a wheel, and the wheel is a wheel, and it's split into 4 quadrants. The first one, I feel like always like I was practicing this earlier, and I felt a little bit like a cheerleader, which, little known fact, I was one. So that might be where it's coming from. But the 4 quadrants of AMBIT are the client is at the top, the team is over here, the learning network is here, and the network is here. So it forms this wheel. And with this wheel, we always want to make sure, or we want to try our best. I'll try not to speak in absolutes. When I get excited, I get into absolutes. We want to try our best to make sure that our attention is going equally to each quadrant. When someone comes to me and they're working in an AMBIT case and they're really struggling, either they feel stuck, they feel overwhelmed, I usually sort of look for what part of the quadrant isn't being attended to. And I kind of go there first, and we practice some mentalization there first. Sometimes I'm completely wrong, and that's fine, and we sort it out in another way. So going over this wheel, I really wanted to spend some time today talking about the team. I usually, when I discuss the wheel and the quadrants of AMBIT, I start with the client. I'm not going to do that for a couple of reasons. One, because I think Shweta did a great job talking about a client that could utilize mentalization, that could utilize AMBIT. But also because I often find when I'm consulting with my team members that it's the team that is sort of needing to regroup. It's not the client. It's not the network. It's the team itself. And I think that's because these clients are complex. These systems that they are in are complex. And building relationships is hard. It's complex. A lot of us are therapists. Our jobs are to build relationships, and it's still hard. So in this team approach, like I said earlier, it's a small team, but this really interesting thing happens in AMBIT, where sort of throughout the wash and getting to know the client, this key worker emerges. And a key worker is not an organizational role. It's not like when I'm assigning team members to a team, I say, okay, Megan, you're the key worker on this. It's really who the client jives with. Maybe it's a temperament thing. Maybe they have something in common, something unique in common. Maybe it's something we'll never quite put our finger on. But this key worker is really key because this is the person that the client kind of thinks, I think this person might be really able to help me. Or, I feel like this person, I might be able to trust them. Because trust, let me tell you, trust is such a big deal in AMBIT, in mentalization, in life. Let's just throw that out there too. But I am just speaking about the system. Without trust, the system does not work. The team needs to trust the team. The client needs to work towards trusting the team. And then the team needs to trust the networks, and everyone needs to sort of feel held. Why this is difficult is because these cases, these AMBIT clients, are typically very anxiety-provoking folks. So moving into the quadrant of the client, our AMBIT clients are typically, they've had relationship struggles. Their expression of their symptoms of BPD or MPD have worn people out. It's pushed people away. They've done this consciously, unconsciously. They've even sometimes, especially when they get to Ellenhorn, they've done this to treatment providers. They've burnt out treatment providers. Sort of Ellenhorn's bread and butter is we really want to work with and take the people who feel like other types of treatment didn't work. And so these clients are often difficult to engage. And so the small team works slowly with them to engage them. I'm back. I'm so glad that's being recorded. But the small team works to engage them. And how we do this is through, different types of therapies, of course, through assessments, through going into the community and being with them. But really in all of this time, utilizing mentalizing. So Shweta, I wouldn't mind to stop talking and just to have you talk a little bit about how we might sort of utilize mentalizing with a client in order to build some trust.
I think you sort of spoke to it, that so the issue with a difficult patient that doesn't trust or is coming in with a history of, mistrust of providers, caregivers, and has no experience of relying on people, so it's difficult to start with them. And I think mentalizing, meaning like what you said, Shelly, that instead of us going in as assuming that we know what's going on, and we have something of useful to offer to the patient, we actually go in wanting to elicit from the patient as to where they are. What do they think about what's going on? So we are not the expert. I think that's one thing that mentalizing offers. That back to the idea that mental states are opaque and we don't really know, and we have to learn it from the client, from the patient, that they have a lot to teach us about what's going on with them. And I think just doing that, my experience of working with patients at the clinic, which is sort of is the same population that Shelly is talking about, except that we are working with them in the hospital rather than in the community. And when you actually approach the patient from the stand saying, you tell us rather than us telling you, I think that starts with, that opens the door to that maybe there is a possibility of developing a relationship where this person is going to respect me, is interested in listening to me, is interested in how I think about what my struggle is and what I need. I think our sense is that the patient actually, it's not just one conversation, but I think the stance goes a long way. Goes a long way, yeah.
Oh, and you hit on something that I sort of left out, and really, to be completely transparent, wasn't even thinking about sharing today. But this idea of this shared language, right? Each sort of client we are doing MBT work with, mentalization-based therapy, or we are having on an AMBIT team structure, we're really learning their language. And this is something each AMBIT team will do is, of course we have our typical Ellenhorn jargon, every company does, but we might start sort of when we're talking about a certain client, use their words, not ours. And a really simple example of this is working with a client who is really, really depressed, but they call their depression anxiety, right? It feels like anxiety to them. But if you look at the DSM, if you diagnose it, it's depression. I'm not going to sit there and argue with this client and say, no, you have to go with my jargon. Like, okay, if you want to call it anxiety, we will call it anxiety because that's how it feels in your body. That's how it feels in your life. That's how it's impacting you. And that's what's most important to me. It's not most important to me or my teams to be the sort of the smartest in the room, right? Or the one to sort of hold the upper hand. And going back a little bit to this shared language and working with these clients that can be difficult to engage and cause a lot of anxiety, it's really important for the team to explicitly mentalize with one another. We can implicitly mentalize with one another, but if we do that too much, if we implicitly mentalize and then we get busy and then we stop checking out what we're thinking and then we just assume what we're thinking and then we get certain, the team starts to lose connection, right? So really in your team discussions, in your reports about your work with the client and your supervision, working explicitly as a team member to say, hey, can we pause there for a second? Can I get curious with you about this? What did this mean? What were you feeling? Because much like our clients can move into pseudo-mentalization, pretend mode, and all these other non-mentalizing modes, we can as team members as well. Because this isn't something that we do because we have a mental illness. This is something we do because we're human and we have a brain, right? And so really being sort of explicit on your team about your curiosity. I have a funny example of this that some of my old Pathfinder coworkers will probably like. But when I first started at Menninger, it was my first sort of step into working in mentalizing, working in a culture within mentalizing. And we had a client, and in report, they were talking about the Dr. Oxford, who was my boss at the time, was talking about the client, and I was kind of disagreeing with what she was saying. And I think because I have a very expressional face, she could tell. And she came up to me after report and said, would you tell me if you thought I was full of BS? And I was sort of taken back because I came from this system in which the boss was sort of always right and you didn't question the boss. And I think I sort of said, do you want me to? And she was like, yes, I want you to. I want to be able to have these discussions. And that sort of explicit laying out of, hey, I want this to be a discussion. I want you to be curious about my mind, and in turn, I'll be curious about yours, was so sort of pivotal for me in this work. And it really sort of is something I've brought to Ellenhorn in my work there. And it was there too in Ellenhorn when I got there. But it's something I really sort of sit on, is that if you're on an AMBIT team, we need to talk about the countertransference. We need to talk about the transference. We need to talk about, to put in layman's terms, the BS in the room. And we need to talk about it curiously and respectfully, because it's going to come up. And so with my specific team members, I say, not only do I want you to be open to feedback and curiosity and sharing your mind, I want you to be open, even though I have a director's title, to give feedback to me, to be curious about my mind, to say, I don't know, is there another way you think we could manage that? Because once again, going back, that AMBIT sort of spreads out this hierarchy so that there's not sort of like the smartest person in the room. Shweta, I don't have a direct question for you, but I was just wondering if you had any thoughts or any examples that sort of popped up as I was speaking.
Well, I wanted to go back to your example of where the patient calls their distress anxiety, but you have a feeling that that's depression. I think you do want to, I don't know what you think about this, Shelly, but my sense is that I do want to get to a place with the patient where I can sort of acknowledge that, gosh, that the, really get, regardless of what we are calling it, really get a good understanding of what is it that they're describing, their felt experience, and can also openly say, what this makes me think of is depression, as I understand depression. It is really interesting that what this makes you think of is anxiety. So I do want to create a relationship where I am not, just going along with the patient's mind. I'm interested in their mind, but I'm also holding my own mind. And we want to exchange our minds, not necessarily agree, not necessarily get to, one mind knows better. But this dialogue of, that there are two different minds in the room, or there are 5 or 7 different or 10 different minds in this group, and that we are all enriching, learning from, being surprised by each other's mind. I think that's the essence of this kind of approach.
I love that you said that, because it's so true. And it also makes me think about this idea that these teams, these AMBIT teams, they start small. And my hope is we can add people to the team as we go, that once attachments feel stable enough, and that once we can engage in these feedback and these discussions like Shweta is talking about, and really sort of stay in a mentalizing space and stay connected with the client, then maybe we can sort of bring in a new attachment.
So Shelly, now you are talking about, as you're taking care of that, you're also now, I think what you're pointing to is that the other thing that this theory offers, which I think I find it useful, is that you have to keep your eye on the emotional arousal in the relationship or the room. That you cannot, that if the emotional arousal is too high, then the person cannot engage in the kind of reflective thinking that we're used to doing in therapy. So we actually have to not invite that, not expect that. We actually have to lower down our expectation to where we say we only validate. We validate their experience, because the idea is that the validating and understanding their experience is going to bring the emotional arousal down. And once the emotional arousal is down, then we can, get back to being more curious and reflective.
Yes.
Yeah.
And we have to do this on our teams as well, right? I mean, I don't know about you guys, but I've been in some pretty heated team meetings in which we're all pretty aroused ourselves, whether there's a high-risk situation, there's a pretty big clinical disagreement, there's some sort of family conflict going on where the family's wanting one thing and we're wanting the other, and the client's wanting a whole nother thing. All of those things bring up the team's arousal. So the team also being aware of when this is happening. And what we have at Ellenhorn is each team has an AMBIT coordinator. And the AMBIT coordinator has been sort of put in the position to call that out and say, hey, I think maybe we need to take a break. I think maybe we need to take a step back, or I'm noticing a lot of emotion in the room, or whatever it is. And we sort of allow these AMBIT coordinators to be that speaker in the room, and that can sometimes help. But I think that's a great point. And it leads me to this next point, which is the network, right? So our clients oftentimes work with these complicated networks, right? Sometimes we can sort of put the family in the network. They maybe have other medical providers. They have teachers. They have anyone who sort of is not, or who's, sort of like helping with the treatment, helping with the progression forward, is sort of considered part of the network. And when we're working with these networks, where the anxiety can sometimes play is that I just started echoing. Can someone mute themselves? Okay, sorry.
You sound okay now.
Okay, good. Hearing your voice back is like an awful experience for some. I don't know if anyone else experiences that, but I don't like it. But anyways, going back to these networks, It can be anxiety provoking to work in these networks because they might not work how we work. They might not want to take a call once a week to talk about client progress. They might be hard to get a hold of. They might be really busy. They might not understand that we're doing this work with a client where we're letting them develop their own language. And then we're sort of going to start this reflective sort of piece. And then we're going to start this like, you know, nitty gritty work. I've oftentimes had to explain to parents before, they're like, you're letting my kid off the hook too easy. And I'll be like, I've only known your kid for a week. If I start calling them on everything I see right now, I'm going to lose them, right? So being able to explain this system to the people within the network and sort of figure out how to creatively and flexibly pull them into the system in a way that feels helpful to the client. Because in these sort of complicated systems, there also might be people at play who aren't helpful to the client, or the client feels like they don't have a voice to sort of speak to. Like, I don't really want to stay connected to that doctor or that therapist that my parents made me see when I was 17 and now is still sort of a part of this. And so helping sort of the client find their voice and how to speak and advocate for themselves in this network can be really important.
Shelly, how does the team uses the key worker?
Yeah, so the team uses the key worker in a couple of different ways. So the key worker is, you know, the one who is most connected to the client. They are typically the one who understands the client's mind best. And oftentimes when we're in a team meeting and we're talking about, okay, we have to deliver this message to this client that she's going to need to move into a sober living, we oftentimes look to the key worker and we say, you dropping into the client's mind, how do you think they're going to take this? What do you think the best approach might be? Can you really help guide us? And then we can sort of think together and problem solve from there. And it might be that this key worker then has the hard conversation with the client, right? That might be the best person. Other times it might be someone else has the hard conversation with the client and the key worker is sort of there as a cheerleader, as an advocate, sitting side by side that person. Another really creative way the key worker has been used, and I don't believe Erin is on this presentation, but if you've been in presentations with me before, you probably met Erin Kane. She's an AMBIT coordinator in Boston. And she was working on an AMBIT case as a nurse, and the client really, for whatever reason, was not connecting with her, did not want to meet with her, did not want to do sort of the nursing duties, which were pretty much just packing meds. And how we pack meds at Ellenhorn is we go to the client's place of living or they come to the nurse's office. We sit down side by side, we pack them, there's talk. We shift the responsibility to the client to sort of help integrate them back in the community. This client didn't want any part of that. He didn't like Erin for whatever reason. And so instead of forcing the relationship, instead of being like, no, you have to do this, right? You have to meet with this person, or the opposite, instead of just sort of kind of moving into our own pretend mode and giving up and saying, Erin will pack his meds and just drop them off at the door. It's fine, you know, which wouldn't be teaching him the skills he's there to learn. The key worker was pulled in. Erin taught the key worker how to pack the meds. And they sort of did some role playing of this is what it'll look like. This is what you need to do. And then that key worker now meets weekly with that client and packs the meds. Which is really cool and would not be possible without trust, right? Without trust on that team. I also think it's not possible without a little bit of humor and humanity, because I don't know if any sort of social worker has tried to sort of help out a nurse before, but sometimes it gets very complicated and there's words you don't even know. And so that's sort of this idea of utilizing this key worker, like to come up with this idea and then to use their time. And that's why it's important to have sort of these outside team members who can sort of step in and say, okay, key worker, now that you're having an extra hour on your schedule a week to do this with clients, what can I take off of your schedule? What can I help you with? Or what can I absorb so you can take on more? Yeah. I think we have a couple of questions and we're about 9 minutes till the end. So maybe we hit on those and I can weave in some stuff about the final quadrant, which is learning at work.
So we have one question in the chat from Megan, and she asks, how does the team support the key worker?
Yeah. So the team supports the key worker in some of the ways I just described, right? In this picking up sort of the extra work and helping them problem solve. But another major way is the team sort of supports the key worker in any sort of emotional space they might need, right? When you're the key worker on one of these AMBIT cases in this system, oftentimes you can be the one who's pulled into the enactments. You get close to the client, you're spending a lot of time together, the transference and countertransference starts to get really activated. And sometimes you get pulled into it before you even know you're there, right? And so the team's job is to sort of be curious with the worker about this. Use some mentalization with the worker to help see where the worker's mind is in all of this, to see if mentalization is still turning on, and to sort of gently stop it when it's not. Did I see another question pop up?
Yes, so it was Shweta, and she asks, what types of patient profiles is AMBIT designed to treat? BPD and NPD was mentioned. Has it also been applied to issues like schizoaffective disorder with paranoid features?
Yeah, so it's been applied, of course, broadly to personality disorders, and it has been applied in cases with schizoaffective or psychosis even. It's really about, I guess the main part of the profile is less about the focus on the sort of diagnostic DSM piece and more about the ability to hold relationships. I see Shweta shaking her head, so I was wondering if she had anything to say.
No, I completely agree. The question was by John. I don't know how to pronounce the last name, but it was just by mistake maybe directed to me. So I just posted it back to everyone. Yeah.
Great.
It's a good question.
Yeah, totally. And when we have a new client sort of coming into our care and we're thinking about this AMBIT system, we're also thinking about what their possible attachment style is, if there's been sort of any relational trauma, those sorts of things, sort of less, BPD and NPD, and more these experiences in life that make it hard to trust others, trust treatment providers. Any other questions from that chat box? I certainly don't want to miss anyone.
There aren't any other questions in the chat, but if anybody has any questions, you can also feel free to unmute yourself and just ask them out loud.
Very good. So, I'll just spend a couple of moments talking a little bit about this learning at work piece, because it's a really important part of the AMBIT wheel. And like I said, it all sort of needs to be balanced. And sometimes when we get busy, when we get anxious, when we're dealing with hard cases, we can find ourselves stop learning, right? We move into our autopilot, we move into sort of our rigidness. And this learning at work piece is really focusing on how do we use our local expertise, of our team to help us with these cases. So the Erin example is a perfect case. Erin's expertise was med packing. She taught her team member that. He learned at work, then he helped the client. So you can really see that sort of part of the wheel in motion, to make a wheel reference. And so this other part of learning at work is making space for consultation, for supervision. It's making space to utilize thinking togethers or disintegration grids, which are sort of two things from Mentalizing and AMBIT that we use, to really make sure we're taking care of our own minds in this. And it's not about moving outside of what we're trained in. It's about utilizing the people around us to help. So it might also look like, I had an AMBIT client once who was working with a therapist on some anxiety and OCD related symptoms. I talked to the therapist weekly, and then the client and I in the community did the exposure with response prevention, right? So I'm in no way an OCD expert, but I could utilize Dr. McLean to help come up with a plan, and then me and the client could do it together. And that's a big, important part of both the network and learning at work that can be engaged in this system of care.
Broadly, the idea of team makes me think of, like we're saying that, in a trusted relationship, we become more confident to explore our mind and explore the world. And so team, if you think of team supports everybody's mind on the team that we all need. So patient needs us, we need our own support network in order to keep the mentalizing online. Yeah.
Beautiful.
Which sort of fits with the, like DBT, for instance. The DBT has the team, the model is that you would have a team when you're working with very difficult patients. So it's
Right.
sort of across the board makes sense.
Totally. Yep.